Hello! Do you want to understand how Ozempic and Zepbound affect fertility and pregnancy and what should you do with them? Well, you're in luck. Today we're going to be talking about those things on First Friday Fertility. I'm Dr. Preston Parry, and I'm actually going to be going with some of the latest data from obstetrics and gynecology. This is the Green Journal. This is one of the most common journals that people in our field read for OBGYNs in general, and saying, what have we learned about how these medications affect fertility and pregnancy? Of course, this is not individualized information. Anything you do as a prescription and for clinical management should be run by your clinician to guide things, but this will talk about general concepts and what we should be thinking of. The GLP-1 class of medications, that's your Ozempic, Zepbound, etc. Those are ones that are starting to radically transform where people's weight is. And so if you look at what the GLP-1s do, they serve, not only do they cause weight loss, but so that people feel full faster, they have fewer cravings, and it also delays gastric emptying, so that basically the stomach ends up being more full because things aren't moving through as much, so people feel fuller for longer as a result of that. That's really an important thing to think about, by the way. And so if you look at the data on what happens when people lose weight, most of it focuses on diet and exercise. We really need better studies for people taking GLP-1. You know, again, I keep saying it because everyone's like, what is a GLP-1? You know, your Ozempics and your Zepbounds and things like that. Weight loss clearly does help with live birth rates, and spontaneous pregnancy. It's not as clear for IVF right now, and I just want to be specific on that. If you extrapolate, you'd expect it to do better. But again, the problem is a lot of things for IVF, if you have very high chances, even if you're slightly lower, if you've got a 50% embryo that went to 55% from weight loss, but you've got 6 embryos, you really can't tell the difference that easily between 6 50% chances and 6 55% chances. And again, we need better numbers on that. Also for men, there are some things that show that if a guy goes on these medications, not only does it help with weight loss, but it will improve sperm counts, it'll improve the volume, it improves testosterone levels with 15% of weight loss. So that's something that also may have a meaningful impact. In fact, sometimes I focus more on weight loss for guys than I even do for women, because a lot of guys who are heavier have such large thighs, it sandwiches the testes, and it boils them in some ways when they're trapped between the thighs, and as a result that can lead to meaningful impacts on sperm counts. In terms of how to improve pregnancy, if you lose 5 to 10% of your weight, for people who are overweight or obese, you can see meaningful improvement in obstetrical risks. And this lowers preeclampsia, gestational diabetes, preterm delivery, a thing called stuck shoulders, which is known as shoulder dystocia, stillbirth, and even maternal death. So weight can have very meaningful impacts on that, as well as ultimately for the baby. When the mom is lighter relative to heavier, she is less likely to have the child end up in the neonatal intensive care unit and less likely to pass away or die. So these things matter. And again, for what we do for our kids, while I would say a lot of weight is not in our locus of control, if we can find ways to lower weight, that may give us better outcomes. And again, this is for where some of the debate is. The problem is for doing GLP-1 in pregnancy itself. And right now, there's some animal data that actually says if you give it to animals, they have problems with the bone formation for the babies. There's things for being, and it so affects the skeleton. There can be things for being small, possibly even lower fetal survival. It depends on what the nutrition is. There are some other things that go into it. But right now we're saying, we may want to hold off and not do the GLP-1s in pregnancy itself. The challenge is some of the data on this relates to people who need the medication and then is comparing it to people who don't need the medication. The largest study that's ever been done right now, a guy named Sesta, showed he looked at almost 52,000 people between North America and Scandinavia, and also Israel. And with this study, if you compared people who were taking the GLP-1s versus those who are taking diabetic medication for really insulin, you found really no difference clearly in the birth defect rate. So it may be also some of the risk is that people need the medication rather than they got the medication. There's a much smaller study by a guy named Dow, D-A-O, and that showed really they saw no difference in birth defects from those taking it versus not taking it. But I think, again, we're going to need more data. But I think what we're going to find is that the recommendation right now is you should be off probably the semaglutide, tirzepatide, really for 2 months before pregnancy for the semaglutide, which is Ozempic, Wegovy, Mounjaro, and Rybelsus. And you have a little bit of a shorter half-life with the Zepbound. That is, in the more the 5 days than the 7 days. So some people are saying more a week and a half. But the quick version is right now, until we can have better data in research settings, probably not wanting to go on those during pregnancy itself. And the other thing I think that's very important is, hey, you finally lost all this weight. I stopped the medication. You can then start having a yo-yo or a cycling effect. So what do you do to sort of keep the weight off? And that's something you work with the prescriber originally for things. And there are things like Buspar you can take, or metformin. There are several things, and you have to see what's indicated for the individual, as well as sort of diet, exercise, things like that. But there are options for medications that are a little more accepted for pregnancy. Again, this is all evolving, and I know this is a lot of information, but the quick version is we're going to try to have people off, these medications a month and a half, 2 months before pregnancy is the ideal, and then we're going to probably adjust as we see things, so more data emerge that tells us, is this more safe or less safe? If you have questions on any of this stuff, let me know. I'm always game for answering anything and everything people will throw at me. Remember, any of this is general medical information. Any particular plans of action need to be coordinated by you or friends with a clinician. But good luck on your journey, and I hope this helps.